Hi, everyone. I'm Dr. Sabbagh. I'm one of the reproductive endocrinologists at Boston IVF, and I am happy for those of you who are joining me today. Happy to answer any questions you may have. I currently see patients in the Concord office, which is one of our new offices that opened a few months ago. But I do see patients virtually, so looking forward to meeting any of you in the near future. And thank you for joining me during your probably lunch hour, and happy to answer any of your questions. One question that was submitted was, what is the percentage of success for each intrauterine insemination cycle? Roughly, I would say the percent of success for an IUI or intrauterine insemination cycle, we say is about 10% chance of success per cycle. I know that doesn't sound very high, but usually when you have infertility or when you've been struggling to conceive for about 6 months to a year or more, your chances of success on your own without any assistance is about at most 5% or less per cycle. And so by doing the intrauterine insemination cycle, we are boosting your response to about 10%. So it is not negligible at all. One question that came in is, what protocol do you like best for diminished ovarian reserve? For diminished ovarian reserve, it is definitely tricky and a difficult diagnosis. We tend to start with our typical protocol, which is what we call the antagonist protocol. So when you're taking 2 injectable medications to start with, and then we add the antagonist, which helps prevent you from ovulating prematurely, because that is the protocol that tends to work for the majority of patients. So we tend to start with that. But we do have other protocols that we like to use if that doesn't work, but I would definitely give it a fair shot first. Things like a microdose Lupron protocol, or probably using like an estrogen lead-in to your antagonist cycle. Those are other alternative options as well. Another question is, what is the average amount of embryos collected during a retrieval? That is a very subjective answer. So there isn't a specific number that there isn't an average number. Basically, it'll depend on your egg reserve or your anti-Müllerian hormone. So those of you on the higher side from an AMH standpoint will have more eggs, potentially leading to more embryos. And for those who have a lower ovarian reserve, less eggs leading to less embryos. But I would say there isn't an average number. And we do get asked that quite frequently. And I don't want anyone to get fixated on specific numbers because it'll depend. It is very patient dependent. A question is, just had my first embryo transfer on Friday. Yay, congratulations, good luck. With Asherman syndrome, is it harder for the embryo to attach? It is a 5BB and hatching already. So for a 5BB embryo, those are good quality embryos. So we like, usually in terms of criteria for when we freeze them, anything with 3 or above, it's how expanded the embryo is, and an A or a B from a grading standpoint. So 5BB is a good quality embryo. From an Asherman standpoint, it'll kind of depend on the degree of Asherman's and if you've had any procedures prior to kind of help correct that, or if you've had a hysteroscopy to help remove some of the adhesions that have been created. Usually, once you get to a point where you did the embryo transfer, I would assume that your reproductive endocrinologist has already gone through that and has potentially helped treat the Asherman syndrome. So as long as the lining of the uterus looks good and that there isn't any residual adhesions, your chances of success should be similar. Another question is, just had my first egg retrieval on Monday. Congratulations to you. We obtained 20 eggs, but only 8 fertilized. Will my doctor be able to tell me if this is likely due to the quality of the eggs or the quality of the sperm? That is definitely a good question. It's always something we try to juggle, like what is the cause of lower than expected outcomes? Is it egg or is it a sperm issue? I would say 8 out of 20 is definitely lower than expected, but that will depend on several parameters. From these 20 eggs, how many of them were mature? Because if the maturity is on the lower side, then maybe it is an egg issue, meaning if only if only half of them were mature, then 8 out of 10, for example, is a normal amount for fertilization. So it'll depend on that. And then also on what type of fertilization was used. Was it regular insemination or was it ICSI, intracytoplasmic sperm injection? So that can also play a role, so they can make different tweaks with a subsequent cycle to help with the fertilization. And then also will depend on how the embryos developed. So did they stop or arrest development early? Did they make it to development later? Those are all different things that we take into account when we decide if it's an egg or a sperm issue, as well as your prior history and testing that's been done. Does the quality of the eggs improve with treatment? So the egg quality is definitely not something that we can measure with like a blood test or anything. So quality is usually based on age. So the younger we are, the better the quality of the eggs. And the older we get, the quality does tend to decline. There isn't anything specific that we can do to improve the quality. And so there isn't anything that we're doing with treatment to improve the quality of the eggs. What we're trying to do is circumvent certain other factors to help improve your outcome. So we're not improving the quality of the egg per se, but we're just trying to improve outcomes with different things, if that makes sense. How many failed IUIs do you recommend before moving to IVF? So I would say that would depend on your diagnosis. So if you are doing ovulation induction or ovarian stimulation with an intrauterine insemination, for example, for an ovulatory disorder, then I think it's fairly reasonable to try for about 6 tries or 6 months before moving on, because we tend to think that that's probably the reason why you're not getting pregnant. And most people, I would say, would get pregnant within 6 months of trying. If you're doing it for other reasons, or for example, for unexplained infertility, when all your testing came back reassuring, then we do have some data actually published from our from Boston IVF, where the chances of success start to decline anything after 3 to 4 cycles. So we tend to say to kind of reassess the situation after 3 to 4 cycles and talk about potentially moving on. I've had 2 genetically tested embryos that I miscarried. What other testing can be done? I'm sorry for that. That definitely is not a common outcome, but it can happen. So in terms of chances of a live birth, so it is 60% chance of success when you transfer a chromosomally normal embryo, so an embryo that underwent PGT or pre-implantation genetic testing for aneuploidy. But it is not 100, because there are other factors that could play. And so in terms of other testing that can be done, I think a workup for recurrent pregnancy loss would be warranted in this case, since they both miscarried. So taking a look at the uterus, doing a uterine cavity evaluation, making sure everything there looks normal, testing you for different conditions, like making sure your sugar storage or your HbA1c is normal, the thyroid, the prolactin. Also checking what we call antiphospholipid syndrome panel, checking you for these are things that can increase risks of clotting or miscarriages. And so those are several things that we would recommend testing for, given your history. I've had 20 follicles leading up to my egg retrieval, but only 8 were retrieved. Can follicles not have any eggs? Yes, that is definitely possible. So we always say not every follicle contains an egg, and it also will depend on how large they are. So, those that are at least 14 millimeters or more tend to potentially contain an egg, but they don't all. And it'll depend on different factors. And so the fact that 8 out of 20 contained an egg, though, is less than expected, and I know disappointing, but it definitely can happen. So they do not all contain eggs. Does the chance of success at IVF go up or down per cycle? So that's an interesting question. So in terms of success rate, definitely it's a numbers game. So the more you try, you can be successful with several different tries. A lot of patients have to go through more than one cycle to be successful. And so I would say your chances are fairly similar per cycle, but we do learn a lot from one cycle and potentially make tweaks with a subsequent one that can improve your outcomes. We tend to say that once we get to a higher number, so if you've gone through 4, 5, or 6 cycles, then at that point, the chances of success start to decrease because we've done everything that we can think of that can help potentially improve your outcomes. And at that point is when we start talking about alternative options. I've had 2 IVFs, and the first took out 19 eggs, and in the second, 15. But in the second, only fertilized 1. Is there any reason for that? That definitely is lower than expected. It would depend. I'm not quite sure how many of them fertilized in your first cycle, but it would depend on the sperm parameters. So definitely the sperm counts are variable. They do change with time. And so if the counts were different or the parameters were on the lower side during that time, that could affect fertilization. What type of fertilization was done as well could impact it. And then the maturity of the egg. So sometimes the quality can change from one cycle to another. And a lot of the times it's just a one-off, but it is a disappointing result. So those are potential reasons why this could have happened. We are trying with my partner for over a year and a half, and I've had a miscarriage around a year ago. And since then, we are trying without success. What are the tests my partner has to do? And so I think that now that you've been trying for over a year, it does warrant an evaluation for both of you. But to answer your question from a partner standpoint, we usually would have them do a semen analysis. So we're doing an analysis of the sperm basically and looking at different parameters there. And then that's basically the part of the workup that we would do for men. And then I would also recommend that you get tested as well, since it's been both of you that have been trying, but that's what we do for your partner. It would be a semen analysis. Would PGT-A testing at age 32 to 33 make a big enough difference to justify the out-of-pocket cost? My doctor doesn't recommend it because of my age, but I'm worried about my experience of failed transfer and wasted time that I could avoid by knowing which embryos are genetically normal. So there is a lot of studies that were done on PGT and its use in different age categories. In general, in patients that are under 35, we expect the majority of their embryos to be chromosomally normal. And so we tend to not be as recommended when you're under 35 because we expect similar success rates where the majority are chromosomally normal. And all the studies that were done didn't show any changes in the live birth rate. However, when you're older, so there's very good evidence when you're 38 and above that it is beneficial and kind of this gray zone between 35 to 37. That being said, a lot of patients, even at the young age of 32 to 33, do opt to do PGT, and for various reasons. For example, if you've had several failed transfers or if you've had miscarriages that were due to chromosomal abnormalities, then you could opt to do the PGT testing, though it is an out-of-pocket cost because it is considered an elective test. So I don't think it is unreasonable in these cases to consider it, though we know that we do have good data to prove that it likely won't make a difference in outcome. But I do understand that with several failed transfers, it could potentially shorten your time to pregnancy, meaning we are eliminating the embryos that may not implant at all or lead to a miscarriage. So it can shorten your time to pregnancy. What is the percentage of success getting pregnant at age 40 going through IVF? So at age 40, that one will depend on your ovarian reserve, because that, depending on that, we'll know, because when you're 40 or above, or at any point, it is a numbers game. So the more eggs we start with, hopefully will lead to more embryos. And the main issue at age 40 is that a lot of the embryos will be chromosomally abnormal. about, 85 to 90% of them will be chromosomally abnormal. So starting off with a large number of eggs leading to a large number of embryos can potentially help getting some that are chromosomally normal. So I think that's the main thing. But in terms of a success rate standpoint, and this is just like doing an IVF cycle, and if you get an embryo, I would say is about a 15 to 20% chance of success. But once you have an embryo that is chromosomally normal and tested, it goes back to the same chance of success irrespective of age. So 60% chance of a live birth if you have a chromosomally normal embryo. What is the average number of eggs retrieved? I had 13 eggs retrieved and 2 came back genetically okay. I'm assuming you mean 2 embryos came back genetically normal. I think that's a very good result. So again, the average number of eggs, there isn't a specific number that we quote because it'll depend on everybody's ovarian reserve. But I would say 13 is a really good outcome. It's a very good response. And the fact that 2 came back chromosomally normal is also, to me, a very positive response. Again, it depends on your age and how many embryos were biopsied. To know on average how much we would expect, but there is an attrition that happens between the egg retrieval and how many of them make it to embryos and how many of them make it to embryos that are normal. But I would say from 13 down to 2 that are normal, that's fairly average and a good response. What is my chance of live birth with endometriosis? I've had the surgery to remove it, but it didn't help me get pregnant. Now we're doing IVF. So endometriosis is a very tricky diagnosis because it has varying degrees and it can affect some patients' fertility, but not others. And so it's hard to say exactly from a success rate standpoint, but the fact that you've had the surgery, it has been shown sometimes that people that do go through surgery can improve their chance of success. And I am sorry it didn't quite work if you're trying to go through this naturally. But if you are doing IVF, it will definitely improve your chances. It'll depend again on your ovarian reserve. I'm not sure if you've had surgery to your ovaries because of endometriomas, where your ovarian reserve could have been compromised. But if you have a fairly normal ovarian reserve, I would say your chances should be fairly similar to anybody else. What type of testing is done before a frozen embryo transfer beyond blood work and baseline ultrasounds? So before a frozen embryo transfer cycle, the main thing we want to make sure looks normal is the uterine cavity. So you do a cavity evaluation, and that can be done via a saline sonogram, where you get a catheter placed inside your uterus, and we inject some water in there to help take a look inside to make sure there isn't any scar tissue, any polyps or fibroids or anything that shouldn't be there. That's the main important one. And we do baseline blood work and ultrasound, especially since if it's had been a while since you've done the prior ones, to make sure everything looks okay. But that would be the main thing we check before a frozen embryo transfer, is that the cavity, the inner part of the uterus, looks normal. Do you accept a semen analysis done outside the US? We do accept outside labs or outside. We're not going to make you repeat a test that you've done, as long as the testing looks, the parameters that we're looking for are there. For a semen analysis, I would say that if any parameter looks abnormal, we tend to repeat it, not because we don't trust that result, but because we just want to make sure if it is a persistent abnormality or not, because sperm does change, and so we always want to get another sample if it was abnormal. Otherwise, we definitely accept semen analysis from outside clinics. I had 12 embryos frozen from my first IVF cycle, but we couldn't do a live transfer because of my hormones. We are now in the process of doing a frozen embryo transfer. What's the chances this first transfer is successful? Should I have had the 12 embryos that I froze genetically tested? I think 12 embryos is an excellent number. It's definitely on the high side. So that's really good. The chances of success will depend on your age. So if they're not tested, it'll depend on your age. So I can't quite give a specific number. It really does depend on how old you are. I would say if you're under 35, it's about a 40 to 45% chance of success, and then it gets lower as we get older. And so I So should you have had the embryos genetically tested? Again, that depends on how old you are. If you're on the younger side, we have very good data to prove that the live birth rate is probably going to be similar, so potentially not. But if you're on the older side, having 12 will give you a fair shot because hopefully some of them in there are chromosomally normal and will lead to a live birth. Can you talk about the gestational surrogacy process? That's a big question. And so in terms of the process, we at Boston IVF at least have a team that is our third-party reproduction team that helps with that. And so the way the process works is, you meet with your reproductive endocrinologist and we talk about different things. And there are different reasons why, gestational surrogacy or gestational carrier is chosen. So be it for medical reasons or elective purposes. But in Massachusetts, we usually do it for medical purposes. And so you would talk with the team that is involved with that to kind of go over insurance and cost and what that looks like. And then once a gestational carrier is identified, they go through a series of tests and to make sure they are fit for that. You go through several counseling sessions for you, your partner, the gestational carrier, and as a group. And then in terms of what the process looks like after that, it'll be basically a frozen embryo or an embryo transfer cycle for your gestational carrier. That's the gist of it, but definitely a lot more that goes into it. Are there any proven ways to improve egg quality? So unfortunately with egg quality, it's dependent on age. The younger we are, the better our egg quality is, and it starts to decline as we get older. The one thing I would say that can worsen your egg quality is things like smoking. Those are proven things that we know can worsen your egg quality. But in terms of things to do to improve it, I think just leading a healthy lifestyle in general, keeping your weight at a normal level, not smoking or things like that. But is there anything specific that can be done to improve it? Unfortunately not. What is the minimum number of eggs typically considered suitable for an egg retrieval during IVF? That'll depend on your egg reserve and on your age. So that is, there isn't an average number. There isn't a specific number that we recommend. We've done egg retrievals with fishes that have gone 1, and we've done egg retrieval and gone 60. So it really does depend on your age. And so I would say there isn't an average number. How long is recommended between IVF cycles? So there isn't a recommended amount of time between them. You don't technically need a break. At least in our clinic, most people take a break of about a couple months because in order to do another IVF cycle, we need to submit a new plan for insurance and insurance needs to approve it. But from a medical standpoint, you don't really need a break in between IVF cycles, unless you're doing an embryo transfer, of course. I've had 3 perfect embryos left from my previous IVF cycle 6 years ago. What chance do I have for successful pregnancy at age 47? So the embryos, the odds of success will remain the same as at the time they were created. And so if this was done 6 years ago, it's the same chance of success as that 6 years ago. The uterus, we know, doesn't age the same way. So even at age 47, your odds of pregnancy would have been similar had you used those 6 years ago, if that makes sense. What does it mean that one of my eggs retrieved was immature and why was it still frozen? So the maturity of the egg, that depends on which stage of cell division they're in when they're collected. I would say the majority of them are in the mature stage, meaning they're further down in the cell division. And so about 80% of the eggs we typically should be mature. And so when you have an immature one, then they're probably part of that smaller cohort of eggs that were just at an earlier stage of cell division, which definitely happens about 20 to 30% of the time. The reason it can be frozen, I mean, I guess it depends. So a lot of the times we freeze only the mature ones because those are the ones that we know are likely to fertilize. However, sometimes we do freeze the immature ones because they're all frozen together. And so we don't know if a few years down the line we'll have the ability to use these immature eggs. So because it's at no extra anything different for you, then sometimes we do freeze an immature one. That's probably why. Do you think acupuncture helps with fertility, especially after age 35? I think acupuncture is great. So I think anything to help relieve your stress is something I would consider. There's a lot of data around stress and fertility. What came first is kind of like the chicken or the egg. But I would say if it's a procedure that is helping you and that you feel is decreasing your stress level, I would definitely do it. It cannot harm. At what AMH level is success very unlikely? So that again, AMH is not a measure of fertility. So it doesn't tell you if you're fertile or not. It just tells us how you're going to respond to treatment or how many cycles you'll need and how many eggs we're potentially expecting. And so I would say it will depend on your age. And so if you have a good quality eggs, and even if your AMH is on the very low side, you can have high chances of success if you're younger. Now, if you're older with a low AMH, the chances of success are definitely diminished because you probably won't get as many eggs per cycle. We need to do this multiple times to be able to achieve an embryo that's potentially chromosomally normal and can be used. So there isn't a specific number where I would say, the chance is zero, but the success rate definitely depends on your age. So a lower AMH is, you have a higher chance of success if you're younger. At what point do you recommend considering donor eggs? So there are various reasons why patients would opt to proceed with donor egg. And so it'll depend on your diagnosis. So for patients with, unfortunately, what we call premature ovarian insufficiency, meaning they went through menopause earlier than expected at a young age, then that's a point where it's a difficult discussion. But if we don't think they have a viable option, if they've already gone through the whole menopausal stage, then potentially considering donor egg right away could be an option. Now, if that's not the case, but if you've just gone through several IVF cycles, it is very dependent on you and when you're ready. I would say it does take a while from when you're considering it to actually going through with it. And so a lot of the times the discussion starts to happen when you've gone through 3 to 4, maybe 5 cycles that have been unsuccessful. We start bringing that idea up, but there isn't a specific number where we're like, now you should do donor egg. It's totally up to you and when you're ready for it. What happens on the day of the embryo transfer? So on the day of the embryo transfer, I would say it's definitely so there isn't much that happens. The only thing is, for you at least, we usually ask for a full bladder, which is like the most uncomfortable part of the whole thing, because in order to visualize things better from an ultrasound standpoint, we'd like that you have a full bladder. And then what happens is you come in, you'd be placed on with syrups, kind of like at your regular gynecologist. And then we put a speculum in, we clean your cervix off, and then we put a catheter we'll put a catheter that will, and our embryologist helps with that contains the embryo. And under ultrasound guidance, a transabdominal ultrasound, we watch the embryo go in, or at least we inject the embryo in under ultrasound guidance to make sure it's placed in the correct position. We don't see the embryo, sorry about that. We see like an air bubble that's around the embryo, and then we take the catheter, the speculum out, and then you go about your normal day. Of course, you empty your bladder before you go home because that's uncomfortable, but that's pretty much it. Why is it important not to do any heavy lifting or straining post-frozen embryo transfer? I would say that's not entirely correct. There isn't any specific restriction, especially post-embryo transfer. And so, I don't think there's any reason if it's something that you're used to doing, meaning if you're someone that usually lifts heavy weights, you can go about doing that if you're feeling fine afterwards. A lot of people like to take it easy the day of the embryo transfer just because, but there is no medical reason or any restrictions. That's very different from the egg retrieval process, where we do ask that you refrain from heavy activity because of the size of the ovaries, and they can get pretty large and uncomfortable. And so we do ask that you refrain from heavy lifting or anything that's a high impact, but not for a frozen embryo transfer. Why isn't progesterone given with IUI, but with IVF and FET and a frozen embryo transfer cycle? So the thought with progesterone, so when you're doing an IUI, you are ovulating an egg, and that egg potentially, when it ovulates, whatever remains of it will secrete enough progesterone to help support a pregnancy. For an embryo transfer, It depends on what kind of embryo transfer. So if you're doing a medicated embryo transfer cycle, meaning you are taking exogenous estrogen and progesterone, then your body is not producing it. So you need to take the extra progesterone to help support the pregnancy. Now, when it's a natural cycle, it's actually a big debate in our world that do you really need it? Do you not? We tend to give it just because we think that maybe this helps support a pregnancy when we're doing an embryo transfer cycle. But potentially it may just be to make ourselves feel better. And so the thought is that your body produces, when you ovulated an egg naturally, that your body produces enough progesterone to produce, to support a pregnancy. What percent of women have a low egg count at age 30? There isn't a specific number that I can quote actually of how many would have a low egg count. It depends on different factors. Have they had surgery to their ovary before that could potentially affect their egg reserve? Is there a familial thing going on? Is there other reasons for the low egg count? So there isn't a specific percentage that I can quote of women at age 30, but it is a variable number and it has a wide range. So it is not unusual. Some patients do have lower egg count, but at 30, the quality is potentially still really good. So from a fertility standpoint, quality is really important. I never had issues with my period, getting it every 28 days for 5 days since I first got it. All the tests done in the past looked excellent. And so are my partners. I am 35 years old, no smoking, drinking, being active, following a Mediterranean diet. I am disappointed and tired that we're trying with no success, even with us monitoring my ovulation. IVF is our only solution, I think. What are our chances if our tests come back at a normal range? So I think at the age of 35, if you've been trying for about 6 months without success, even if you've been using the ovulation kits or not, it doesn't matter. Because if you've been trying pretty consistently for 6 months, even if you're not using the kits, you have enough sperm exposure that we think most people would have gotten pregnant. So I think it warrants an evaluation. If your evaluation comes back all normal, meaning you have what we call unexplained infertility, I would say that I know you said IVF is our only solution. I mean, it's not the only solution. It is the one that offers the highest chance of success, but I would definitely talk to your reproductive endocrinologist about potentially intrauterine insemination cycles if that's something that you're interested in. And so from a success rate standpoint, it'll depend on which one you choose. But I think at 35, depending on what the egg reserve looks like, you have a fairly good shot. I would say with IVF, it's about a 40% chance of success. And so it's good. What is the threshold to be considered low AMH? So the AMH, the range varies from lab to lab, and I think also based on your age, we would expect it to be in a certain place or not. But I would say anything under 1 is considered low. Is it advisable to have multiple transfer of eggs at age 47 for a successful pregnancy? I'm assuming you mean embryos. And so that'll depend on if they're tested or not. So if they're non-tested embryos, if they are tested embryos, then we usually recommend one single embryo transfer because your chance of success is similar because the uterus doesn't age the same way. So only one. But if these are untested embryos, it is definitely a discussion you can have with your doctor about potentially transferring more than one. There are guidelines in our society about, yes, transferring more than one, especially at age 47, because a lot of the embryos may be chromosomally abnormal. So it can increase your chances of success by transferring more than one. So I don't think it's unreasonable to transfer. Depends again if they're day 3 or day 5. But if we're planning for a day 5 transfer, I don't think it's unreasonable to transfer around 2 at age 47 if they're untested. And it depends on if you've done transfers before and if they've been successful or not. If someone freezes their eggs in early 30s but has ethical religious concerns with creating more embryos, then they intend to use? Are there protocols to only fertilize so many at once? Yes, we can. And so we definitely take that into consideration. And so if you have created several if you've retrieved several eggs and you only want to create a finite number of embryos, then we would potentially unfreeze only a certain number of eggs to potentially limit the number of embryos created. So that's definitely something that we can do. And then the rest will just remain frozen. What is generally the quality of eggs in a 38-year-old? So the quality of the egg, there isn't a number or anything I can quote because quality is based on age. But at 38, the quality does start to decline around 37 to 38 more quickly than it does before. And so the quality is just portrayed by what is the chance of having a chromosomally abnormal embryo. And I would say at age 38, we expect about maybe a 50-50. So about 50% of the embryos to be chromosomally normal and 50% not. So that's kind of what we use as a parameter. At what day can HCG show up on a pregnancy test post FET? And so after an FET, we do the pregnancy test 10 days later because that's when we would expect it to be positive. And I know a lot of you probably do the home pregnancy test before and can get a result if it's positive or negative. But usually we recommend on the 10th day after the FET is when we check the HCG. Is a low AMH and low ovarian reserve the same? Yes. So the AMH, the anti-Müllerian hormone, is a measure of ovarian reserve. So yes, when we say low ovarian reserve, we mean low AMH. That is correct. What are some treatment options for someone with endometriosis? So that is a big question, and it'll depend on, what your symptoms are and what kind of treatment you're proceeding with. So for endometriosis, for someone who, for example, isn't trying to conceive, they're usually on some sort of hormonal medication, either a birth control pill or an IUD to help suppress their symptoms. Now, when you are trying to conceive, we definitely can't give you things that prevent you from getting pregnant. But it'll depend on the degree. So if it's mild and usually, okay, we won't probably not do anything different. But if you have gone through several cycles, or if you do have symptoms, or if you've tried several cycles and we're trying to see if we can do something different, you could potentially sometimes could use a GnRH agonist or Lupron, which is a treatment that you can use for about 2 to 3 months to help suppress your endometriosis, and then jump right into a treatment depending on the degree of symptoms. And if you have endometriosis, for example, in ovaries or somewhere in your pelvis, surgery is another option where we excise the endometriosis. So it'll kind of depend. For a 29-year-old with 12 frozen embryos, how many would be statistically deemed normal? I would say the vast majority at 29, so about 80% of them. So I think out of 12, maybe 9 of them will be chromosomally normal. So I think that's very good chances. But even at the young age of 29, they're not all chromosomally normal. And so they could be, but not all. What is my chances with endometriosis 1 tube and doing unmedicated IUIs? So for this, there's a lot of data. There is data that proves that if you have, other than the endometriosis, but just a diagnosis of infertility in general, usually we would recommend medicated IUIs, so using an agent like letrozole or Clomid to help boost your response. Because they looked at unmedicated IUIs versus not doing anything at all, and they're fairly similar. So using the medicated approach is better. Definitely with 1 tube does limit your chances a little bit because you would hope that you would ovulate from the side that has the tube. Now, it's not to say that, they are not, the fallopian tubes aren't like frozen. They move and everything is very mobile in the pelvis, but and so there is a potential of potentially 1 tube grabbing the egg from the other side, but I would say your highest bet is if you ovulate from that side. So I think with 1 tube and endometriosis, I probably wouldn't try this more than 3 times and would move forward with IVF if unsuccessful. Do you have any recommendations for dealing with stress during the holidays? The holidays are definitely a stressful time for those of you going through the struggles of fertility. And I would say, in terms of dealing with the stress, I mean, you don't have to go to every to every event. You don't have to attend every family gathering or friend gathering. I think that sometimes can put undue stress on the body. You may choose to or not to talk about your journey. And so if there's anybody that's close to you that you like to discuss this with, it can sometimes help. And if they're on the same page or they know what's going on, they could help. Other things would be like trying to find an activity that makes you feel better. For example, going on walks or reading a book, or is it yoga or anything that makes you feel better? I think you should continue doing and give yourself some grace. You're going through a very stressful time. And so saying no to things or telling people that, we're dealing with it, it's none of your business, is not a wrong thing to do. So those are different tips. What is the likely pregnancy with a frozen embryo graded 4AA? The chance of pregnancy will depend on your age. So 4AA definitely is a good quality embryo, but it'll depend on how old you are. So the younger we are, we expect that this will be chromosomally normal, so a higher chance of success. But if we're older, then the chance of chromosomal abnormality is higher. And so that can decrease your chance of success. What is the oldest age for IVF embryo transfer with perfectly tested embryos? What's the oldest age or cutoff for age? So it'll depend. So for IVF, our cutoff is 44, so before your 44th birthday. And that also depends a lot on insurance because they won't cover after that. Of using your own eggs. And for an embryo transfer, if there was an embryo that was created, the cutoff is definitely higher. I believe it's about 51 or 52, or maybe 50 actually, but around 50 to 52 for the cutoff for the embryo transfer if the embryo was already created. After the IVF procedure, when are we clear to travel internationally? So usually after the IVF procedure, you should be feeling okay within a couple days. And so in terms of traveling, I would say within a couple days from the egg retrieval process, as long as you're feeling fine and you haven't developed any sort of complication from it, you should be okay traveling. And making sure that you do have a medical facility around you that you could go to if anything were to happen. From start to finish with an FET, how long does it take with insurance approval, testing, and the actual transfer? That, from an insurance standpoint, I'm not the best person to answer that because it varies. It could take anywhere from 4 weeks to 3 months to get an approval for a cycle. I would say with frozen embryo transfer cycles, maybe slightly quicker than IVF, but again, it will depend. And so realistically, I would say and then if you're including testing, because everything is based on your period. So depending on where you are in your period, it could take anywhere from 2 to 4 months, I would say. Is weight gain normal during IVF stims? A little bit of weight gain is not unusual. You do experience a little bit of bloating during the cycle, so it's normal to gain a few pounds. But I would say if you've gained more weight than expected, then always let your team know because sometimes it could be signs of hyperstimulation where you're building up fluid in your body that could potentially lead to weight gain. So those are different things. So a few pounds is normal, especially the stressful process and the water retention that can come with it. But it usually comes off when we're done. But if you do end up gaining more weight than expected, definitely let your team know so that they can evaluate that further. How many eggs should someone freeze if trying to bank for the future? In terms of the number of eggs, that will, one, depend on your age and depend on just kind of what plans you have. So the younger you are, you may not need as many eggs that will lead to good quality embryos. The older you are, you may need some more. And it'll depend on if how many children do you want? The majority of people don't end up using these eggs because once they start to try to get pregnant, believe it or not, most people don't have infertility. And so they end up being fine. And so if you end up using these eggs, it'll depend on how old you are. For example, if you're they're under 35, we would say for an 80% chance of having at least one child, it's about 15 to 18 eggs or so, but that number does increase if you're hoping for more than one child or statistically higher odds, basically, or if you're older. Can you do both PGT-A and PGT-M testing? Yes, you can. So I would say when you're doing PGT-M, you're also doing the PGT-A. So the same, the few cells that they're collecting for the PGT-M, they also test the chromosomes as well. So yes, we do both. All right. All right, I'm going to take this last question. So how do you find out more about what we tried in the last cycle? I hear terms like ICSI from others. I don't know if that's what we did. How much control over what treatments and testing gets done or not is on the patient? And when do you know when you don't know what, or you don't, how are you supposed to know what to ask for? I would say always ask for what treatments you're going through. This is your body. This is your treatment. Always ask. It's not wrong to see what type of treatment you're going through. In terms of what's been done in your cycle or not, it will depend on several things. So for like ICSI, which is intracytoplasmic sperm injection, that depends on the sperm parameters. So if the sperm parameters are on the lower side, we could recommend ICSI when they inject a single sperm inside the egg as opposed to regular fertilization. Or if you've had a prior cycle where the fertilization was on the low side, then we could do ICSI with a subsequent cycle. But I would say your physician will recommend a lot of testing and make a lot of little decisions and tweaks, but you can know as much as you want to know. And so definitely ask about anything that you want to in terms of how your treatment is going. Is there any process chosen when choosing the embryo that will be used for FET? Yeah, so that'll depend on different things. And so if the plan is for like the lab to choose the best quality, they usually go with best quality embryo first. So it'll depend on what day the embryo was created, if it's day 5, 6, or day 7, for example, and then what quality it is. So they will prioritize the higher quality embryos first, and then go down the line, depending on what's left. You can also, for example, if they're genetically tested, chromosomally tested, we know the number of chromosomes. Of course, we'll transfer the chromosomally normal ones, but you'll know the sex of the embryo as well. So again, it's something you may opt to choose yes or no. But basically, if they're untested, we go by quality. And then last question for today, can a friend of us be a sperm donor? I want to have a child. I'm 36, but I don't have a partner after my husband died. I am so sorry about that. In terms of, and I'm sure this must be a difficult decision that you're making, but in terms of a sperm, like a known sperm donor, it's definitely a feasible option. I'm not going to say no, but the way the process works is that you would go through, at least from our clinic standpoint, you would go through a sperm bank, that your known donor would go through a sperm bank to be able to freeze a sperm sample. And then they go through a lot of testing and a quarantine phase for about 3 to 6 months. So things can get delayed because of that when you're using a known donor as opposed to an anonymous donor, when all that stuff has already been done and you're just purchasing a vial of sperm. So that's the main thing, is that timeline is very different. All right. Thank you, everybody, for joining me today. I really enjoyed answering your questions, and hopefully I'll meet some of you soon.